Hello.
सेटिंग पे जाएगा ना सही
Hello. Okay.
Bismillahirrahmanirrahim. Assalamu alaikum and welcome to all. I'm Dr. Varda Sajal, Assistant Professor at HSA, and a very warm welcome to the 12th Annual Public Health Conference. And our main aim for the conference this year is reproductive health rights in context of the Sustainable Developmental Goals and universal health coverage, leveraging for improving reproductive health rights in Pakistan and South Asian region. The conference aims to strengthen the partnership and collaboration among researchers, policymakers, and practitioners in the areas of reproductive health rights in Pakistan and South Asia. Let me give you a brief introduction of this session. We have gathered here today to talk about policy making for reducing maternal mortality in Pakistan. Pakistan Maternal Mortality Survey, which was conducted in 2019, which was the first formal survey conducted in Pakistan with collaboration of HSA, NIPS, Ministry of National Health Services Regulation and Coordination, DHS, and WHO to deep dig the causes of high maternal mortality rate in Pakistan. Unfortunately, it's very sad to say that Pakistan has the second highest maternal mortality rate. And the results found from the Pakistan Maternal Mortality Survey in 2019, it was found that it's crucial to develop operational policies and implement those policies as a priority in order to reduce the maternal mortality and to enhance accessibility, availability, affordability, and acceptability for health services for population in need. And today we will discuss Health Services Academy, under guidance of Ministry of National Health Services Regulation and Coordination, will highlight the issues that pose hindrance in reducing maternal mortality rates and current intervention that can be modified for better outcomes. I'll briefly tell about that what we are covering in today's session. We will have a thorough look of the Pakistan Maternal Mortality Survey, which was carried out in 2019, associated risk of perinatal mortality, demographic and health public profile of women undergoing induced abortion and cesarean sections, and patterns of service utilization by women of reproductive age. I will now introduce my worthy guests and speakers. Today, I'm very honored to welcome Dr. Tawseef Ahmed and Dr. Nabila Ali to chair this session. Dr. Tawseef Ahmed is a very renowned public health professional. He's a PhD scholar in sociology. He was a key investigator in Pakistan Maternal Mortality Survey at NIPS. He's worked with many local and international organizations. Currently, he's serving as an advisor to NIPS and UNFPA. Our second chair is a very kind lady, Dr. Nabila Ali, to whom I've been disturbing her for the last couple of days. She's the country director for GSI. She's a public health expert and a clinician as well. She has massive experience in effective health programming in Pakistan and is recognized globally as well for generating policy and design programs. We are waiting for our co-chair, but I'm waiting for Dr. Atiya Abru. They're downstairs as well. In discussants, we have none other than Professor Dr. Farid Midhat. He's a name in himself. He needs no introduction, but I will give a brief intro. He's professor of public health and he's head of department in RMNCH HSA. He has worked across the country and has contributed a lot in public health in Pakistan. He's a renowned teacher and a researcher, and he was a key advisor for Pakistan Maternal Mortality Survey, which was carried out in Pakistan. I will grant permission from Dr. Tawseef. May I start the session today? Thank you, sir. Let me introduce my first speaker, a very dynamic personality, Professor Dr. Ambreen Anwar, retired Brigadier Professor Dr. Ambreen Anwar. She's a professor at HSA. She's a renowned obstetrician and gynecologist. She holds both FCPS, FRCOG, and Diploma in Medical Education from Scotland. She is a very passionate clinician and an educationist. She's also rewarded Sitara Imtiaz for her massive contributions in medical and educational field. I welcome Professor Dr. Ambreen for her talk for cesarean section rates and the other factors.
Thank you very much, Dr. Varda, for your very generous introduction. And I'm honored to share with you the findings related to a cesarean section rates and profile of women who had cesarean section, which were gathered. The information was gathered by PDSA in 2019. Can we have the next slide, please? Now, for those who are not related to the medical field, I'll briefly introduce the history of cesarean section. It has been documented to exist since ancient times. And numerous references to cesarean section appear in ancient Hindu, Greek, and European folklore. The first recorded successful cesarean section was done by a military doctor, Dr. James Berry, who was serving as a physician in the British Army in South Africa. And that was in the early 19th century. Now, by definition, a cesarean section is the delivery of the baby through a surgical incision in the uterus, or to be more broad, in the abdomen. The normal route of delivery is vaginal delivery. But once the things are not going the right way, we have to change the route, and that is cesarean section. Now, the commonest indication which exists are only few. Fetal distress, where the baby is not happy. Malpresentation, baby is not lying the right way. Paired progress of labor. The timing in which the baby should come out happens to be delayed more than anticipated. And in the modern era, we are more and more doing cesarean sections for previous history of cesarean section. And of course, in those cases, we have to go for a cesarean section where we need an early delivery to rescue the baby who's unhappy because of any maternal disorders. Globally, the cesarean section rates have risen from 7% recorded in 91 to now 21% in 20. So that is 3 times in 30 years. Next slide, please. Now, the PMS 2019 included a questionnaire for ever married women of reproductive age. That was administered in a subsample of households visited in the survey. The ever married women's questionnaire elicited detailed information about the pregnancies that ended during the last 3 years. So that is around 2015 onwards. It included information about the type of the delivery, and a lot of other information, but relevant in my talk is the delivery route, which could be either normal or assisted vaginal birth or a cesarean section. Among the 14,500 women who underwent the interview, half of them, that is roughly 7,000, had a pregnancy ending during 3 years prior to the interview. Next slide, please. Now, the data analysis method for public health people are very relevant regarding the statistics. Cross-tabulation between the normal and vaginal births and births through the cesarean section to calculate cesarean section rate percentage by selected socio-demographic and medical variables. Statistical significance was established to determine if the rates were significantly different across categories of descriptive variables. And for this, as you all know, chi-square test was used. Logistic regression analysis was also used to estimate the likelihood of cesarean section outcome for selected independent variables after controlling for the socio-demographic variables. So that statistical backgrounds gives a view of the authenticity of the data. Next slide, please. Now, the results we'll share with you. Next slide. Well, the overall cesarean section rate, as you see, comparison between the rural and urban population out of these 7,000 women showed that as compared to rural, the urban had a exactly double rate of cesarean section. Next, please. Now, if we go by women's age, as you could see, the younger the woman, the higher the section rate as compared to the later part of life. Of course, they had previous normal births, so unlikely that for malpresentation or other reasons, they underwent a cesarean section. But this figure is pretty, like in the primaries and in the second births, cesarean section, high rate in younger women. Next, please. Parity. Again, you could see that 26%, 1 or 2 live births who had. So this is the impact of previous one cesarean section. Primary cesarean section will have a repeat cesarean section. That is very evident in the data. Next. Now, by how much educated a woman is, that was statistically significant, that if the woman was educated as compared to illiterate women, the rate was very high. Next, please. If we go by the highest education, the lowest education, again, the percentage was lower, it was just very significant. MA pass लड़की और PhD करने वाला वो तो हाल ही कोई नहीं है, 16 plus. आगे कर. Now, cesarean section rate by wealth quintile, you can see that the highest quintile, the wealthiest, had a higher section rate, and it drops down to the lowest quintile. Next, please. Now, previous pregnancy loss as such did not have any significant impact. Next, please. Now, by the place of delivery, yes, again, it was statistically significant. In government hospital and in private hospital, there was a difference statistically significant. Well, we are not sure about what was the reason, but I would say in government hospital, more midwifery staff and more staff availability did make a difference. And secondly, cesarean by choice is, I think, still not a choice in government hospital. Next, please. Now, percentage of women who had symptoms during pregnancy. Well, I mentioned breech, that is a malpresentation. The baby is lying the other way around rather than the head. The highest rate recorded was that. Prematurity for cesarean section where there are medical disorders and baby is unhappy, we want to take it out before the time. These were the highest ranking, and along with that, diabetes. Next, please. Now, the two main medical disorders that we encounter in pregnancy are high blood pressure, hypertension, and diabetes. So prior to pregnancy, if they had chronic these ailments, of course, their section rate, they will preferably be delivered by cesarean section, and that was statistically significant. Next, please. Now, mean number of problems during the pregnancy, obviously the normal delivery had lesser problems, and those definitely had some problems. That is why they underwent cesarean section. It was statistically significant. Next, please. Now, as I previously mentioned, those with high blood pressure and diabetes diagnosed during pregnancy, again, it showed that they had higher range of cesarean section, which was adjusted for the age parity, wealth quintile, schooling, and residence. Still, it was statistically significant. Next, please. To conclude from this data, it is that women living in the urban areas, those having a higher education, higher socioeconomic status, delivering in private hospitals, and having medical problems have a higher rate of cesarean section. Roughly, that is concluded. Medical problems, that is very good. Next, please. If we reflect from the history, actually the data exactly go in confirmation with the history, early history. It was in the early 19th century, with increased urbanization and growth of hospitals, cesarean section was started. This is, we are talking about western part of the world. Hospital cesarean sections were started being performed. Most rural births continued to be attended by midwives till 19th and early 20th century. till special hospitals for women sprang up throughout the United States and Europe. In urban centers, large number of working class women started giving birth in a hospital because of the lack of family support. In the cities, obstetric was born as a hospital-based specialty that squeezed out midwifery. And the same culture in our population is what we see now. Increasing number of obstetricians have eaten away midwifery. And so roughly why some women had more cesarean section, what we conclude from the data is, was mentioned by Vaida as well, seems a matter of availability to urban and educated women, accessibility to urban women, and of course, the acceptability among urban and educated women. Me and Dr. Batul will share that about 20 years ago, when I started my training, it was really, really hard to beg women, and literally we had to beg the attendants and the women that we have to take you for cesarean section. And now they are begging us even at 8 centimeters that they want a section. So things have changed, but as you can see, the data is exactly in confirmation with the history. Thank you very much for your patience.
Thank you so much, Professor Dr. Amreen Anwar, for making so complex things easier for her. Let me welcome our co-chair, Dr. Athiya Abru. She's a Deputy Director, Ministry of National Health Services Regulation and Coordination. She's a passionate medical doctor and a public health professional. She's worked with many organizations and is currently serving very effectively in the Ministry of National Health Services Regulation and Coordination. Now, let me welcome my next speaker, Dr. Aisha Shiraz. She is director at National Institute of Population Study. She is a very dynamic researcher and a PhD scholar in anthropology. She's a dynamic demographer and population and public health expert. She was project director for Pakistan Maternal Mortality Survey in 2019. And under her direction and guidance, she had chaired many, many huge projects in Pakistan and is currently also doing so. I welcome Dr. Aisha Shiraz to give us a talk on determinants of maternal mortality rate.
कोई और प्रेजेंटेशन चलें, मेरी डिफरेंट प्रेजेंटेशन शेयर हो गई है, चलें ठीक है। अच्छा चलें ठीक है, ओके आगे नहीं हो रही। Sequence of my presentation is as flashed. From 2000 to 2017, the global maternal mortality ratio declined by 38%. And the live births, according to UN interagency estimates, translates into an average annual rate of reduction of 2.9%. This translates into an average rate of reduction of 2.9, while substantive, this is less than 6.4% annual rate indeed to achieve the sustainable development goals of 70 maternal deaths per 100,000 live births. Maternal mortality is the indicator that shows the greatest differential between developing countries and industrialized countries. Pregnancy and childbirth remains one of the leading cause of maternal mortality among reproductive age in low and middle income countries. And this maternal mortality survey estimated the country's maternal mortality at 186 maternal deaths per 100,000 live births from 276 in 2007, which is from Pakistan Demographic and Health Survey. We present an in-depth analysis of PMMS just now. These are some of the declaration and acts. This is the United Nations Commission of Women passed a resolution elimination of prevental maternal mortality. SDGs call for reducing maternal mortality rate to 70 per 100,000, and also national guidelines on maternal and perinatal death surveillance and response. These are some of the laws and declarations. Literature also observed that maternal mortality is quite high, as she also stated, in Pakistan. At regional level, this is the priority area in developing countries and reduction of maternal mortality and morbidity. Studies also shows there should be decline in maternal mortality. This is some global view, but I will just skip because this is, we have time bar. The methodology of this is the survey was that we have conducted this survey of Pakistan, and it included HAK and GB. For this study, we have conducted it is a nested case control study. All maternal deaths included cases from the sampling frame and controls randomly selected of women who had a pregnancy during last 3 years. These cases and controls were not matched, and study has 90% power to detect odds ratio or 1.7 or higher at 95 confidence interval. Data was analyzed. These are the cross tabulation between potential risk factors of maternal mortality and history of pregnancy loss, education, socioeconomic status, and case control status, using chi-square tests and computing unadjusted ratios. We have also done multivariate analysis using logistic regression models, including important risk factors of maternal mortality as a dependent variable and case control status as dependent variable. And we have computed this on SPSS-PC. The statement of problem is that maternal mortality still prevails in Pakistan, and it can be linked to a range of various factors as well as healthcare utilization. And there is a nexus between maternal mortality and healthcare, and there is a need to undertake an in-depth analysis of trends and to identify linkages. And this has resulted over time in from the survey, it is found that it was 276. 186 in this maternal mortality survey. These are the province-wise rates, some of the, but the confidence interval for the provinces is quite high. So this is the national level figure for maternal mortality surveys. The deaths are higher, indirect obstetrics, abortion-related infection. The slides from the age group is very effective and factor and indicator. And it is found that we have 2.83 average for the 35 age. Parity and which is number of children born to a woman, we also found that the odds ratio and unadjusted confidence is 0.86 in between, and the confidence interval is 137 and 0.54 for live births, and more than 5 live births is 1.4. So we have more risk of dying. The past history of pregnancy loss is also observed. For this, we have observed in the unadjusted with high confidence interval rate. The effect of outcome of last pregnancy as the risk of maternal mortality and unadjusted odd ratio and confidence interval limits are also observed. And we have found that this is 2.5 times the women are more likely to die of maternal causes with the outcome of last pregnancy. Effect of seeing a healthcare provider specialized and more experienced healthcare provider is seen for the last maternal health. We have seen that healthcare provider in the last pregnancy is 0.8% die or MW is observed. It is 0.18 times more likely. to die in maternal mortality, and nurse, doctors, midwives had less chances of dying. 2.31% is less likely to die from a maternal cause. High blood pressure in women is a main cause of problems for maternal health care. And it is found that the women with high blood pressure are 2.67 times more likely to die of maternal cause as compared to women with low blood pressure. Diabetes is also very important factor for a woman's health. And we have seen this diabetes, 3.9 women are dying more of a death with having diabetes as compared to women with less diabetes. Blood pressure, we run the odds ratio, and these are that treatment of high blood pressure in last pregnancy. It is found that 11.0 times it is more likely if she has secure some treatment in this for blood pressure, and she is better off. The effect of pregnancy loss on maternal mortality is these are the adjusted odd ratios. We have found that the woman with less than one pregnancy loss are less likely, 0.99 times less likely to die with a maternal cause. The effect of outcome of last pregnancy on maternal mortality shows that outcome of last pregnancy, stillbirth, abortion, and miscarriages also have effect on the women maternal mortality status. And she is 2.74 times less likely to die of a maternal cause if she did not have abortions or miscarriages. Effect of use of family planning on maternal mortality also has, it is, if woman, she's using family planning method or for spacing or for limiting births, she is 5.42 times less likely to die of a maternal death. So this indicator is very important for the maternal health and other health providers. The effect of women education, if a woman is more educated, she is more careful for her pregnancy related effects and all that. And with education, she is 2.1 times less likely to die of maternal cause. Household members' average schooling also has effect on the maternal mortality, that the household members, more than 9 classes pass, if she has her family members, she is 1.26 times less likely to die of a maternal cause. Antenatal care is also an important factor when a woman is going for antenatal care throughout her pregnancy. She is 0.67 times less likely to die of a maternal cause. Antenatal care provider also shows that in the last pregnancy, if she has seen more special doctors and obstetricians and LSW, they are more efficiently catered and cared for in her maternal health care. Effect of distance to the DHQ hospital and maternal mortality was also very effective indicator for this analysis. We have found that the women who are placed near to the hospital or DHQ, she is less likely to die of a maternal death. Effect of high blood pressure in pregnancy also should be very effective if we have taken care for the high blood pressure, she is less likely to die of a maternal death. Effect of diabetes and in pregnancy, as I have shown earlier, it was unadjusted odd ratios, and later on these are the adjusted odd ratios, and it is showing the woman, it is a bit low, but it is still as compared to 2.67 women will be dying who are having a diabetes. Blood pressure is similar case, it is very high. 11.6 women would be likely to die with a maternal death if she is having high blood pressure. These are they were using family planning ratios. She is 6.79 times more likely to be saved from a maternal death. Education is also having a 6 times more likely effect on the maternal mortality. This is 2.8% for schooling. Socioeconomic status, if she is living in a better status and she is from a higher wealth status, she is less likely to die as compared to lowest quintile. The poor women are 4 times more likely to die from a maternal death as compared to women with middle quintiles. Antenatal care from the nurse midwives is better off as compared to DIE and CMW. Residence of place, if she is residing in a urban area, she is less likely to die from a maternal cause as compared to rural area. Reference categories are shown below. This is urban distance to DHQ hospital as well. In the urban area, she is performing better as compared to urban area. These are the risk factors and outcome of odds ratios. The women, the more effective are the women with age at pregnancy 35 or less year are the women. These are high risk factors, and the outcome of last pregnancy, if it is a live birth, it is less likely to die of a maternal cause. Abortion, miscarriages, and stillbirth are more at risk. Using family planning women as a reference, they are less likely to die of maternal mortality, and antenatal care in last pregnancy is also less likely to die of a maternal cause. These are distance from headquarter, distance from nearest town, and lady health worker also have positive effect on the maternal mortality. These are some of the indicators for ANC provider in last pregnancy. These are the risk factors. These I have already shown. The major risk factors of maternal mortality are age at less than 35, more than 35 years. If she is becoming pregnant in age more than 35 years, prior history of pregnancy loss, abortion, miscarriages, and stillbirth, not choosing family planning before last pregnancy, rural women residing in villages with the distance of more than 35 kilometers away from a major city or a major hospital, and deceased women were more likely to have ANC, but were less likely to have seen a specialist or a gynecologist during pregnancy. This is some of the comparison from 2006 and 19. So I would like to conclude that reduction of maternal mortality between 2006 and 19 is marginally significant. No significant reduction in maternal mortality is observed in provinces. Causes of maternal mortality showing some significant changes, increase in proportion of maternal deaths due to obstructive hemorrhage and hypertensive disease, correspondent diseases in proportion of maternal deaths due to diseases, and major risk factors of maternal mortality remain the same. And some of the recommendations for the doctors as well as students of MPH and medicine, many of the factors are modifiable and can be changed over time. Emphasis on provision of quality of pregnancy and delivery care, raising awareness about danger signs of pregnancy, timely referral, and use of contraceptives would be the key intervention as short-term measures. For long-term interventions, improving education and status of women is also required. Thank you.
Thank you so much, Dr. Aisha, for making such complex things very easy for us. And for all the participants and the guests, you must be surprised at why are we talking about so much about Pakistan Maternal Mortality Survey, because all our worthy guests, Dr. Fareed, Dr. Tausif, Dr. Nabila, Dr. Atia, Ms. Rabia Zafar, Dr. Aisha, Ms. Qudsi Ozma, they all have been part of this maternal mortality survey, and they have done a lot of work for it. It has helped us a lot to dig deep the causes of maternal mortality. Let me introduce my next speaker, Ms. Rabia Zafar. She's a master's in anthropology and is a research fellow at NIPS. She's an experienced researcher in the field of demography, reproductive health, population and development. She was also an essential part of Pakistan Maternal Mortality Survey in 2019. Today, she will be talking about the utilization of health services during pregnancy, childbirth, and postpartum period.
Bismillahirrahmanirrahim. My paper is on patrons of health services utilization during pregnancy, delivery, and postpartum period. These are my co-authors. As we all know that good antenatal care increased stillbirth attendance and postnatal care protects mother and newborn from maternal and neonatal morbidity and mortality. Government is committed to enhance the availability and quality of antenatal care services by increasing access to institutional deliveries and skilled birth attendance. Primary healthcare services were also extended through the Lady Health Workers Program to provide MNCH services through home visits in rural areas. The objective of the paper are to assess the patterns of health services utilization during pregnancy, delivery, and postpartum period, and to examine the socio-demographic determinants of antenatal care, delivery care, and postnatal care in Pakistan. Data sources: Pakistan Maternal Mortality Survey 2019 interviewed ever married women of reproductive ages 15 to 49 years about health services utilization during pregnancy, childbirth, and postpartum period in the last 3 years. Rates of maternal health services utilization were computed by women's biological and socio-demographic characteristics. Logistic regression analysis were carried out to estimate the likelihood of maternal health services utilization after adjusting for the socio-demographic variables. Now I will present the bivariate analysis result for some selected indicators. Next. For this analysis, we have used the indicator ideal antenatal care, which includes 4 and more visits to a skilled health care provider during pregnancy, at least 1 visit in the first trimester, blood and urine tests carried out, and blood pressure measured, iron tablets prescribed, and nutritional counseling given, at least 1 tetanus toxoid injection received. Overall rate of ideal ANC is found 20.5%. Percentage of women who received ideal ANC, skilled birth attendance, and postnatal care in a health facility by background characteristics. The first disparity, bivariate results show that mothers having 1 to 2 births receive more ideal antenatal care compared to mothers having 6 or more births. Skilled birth attendants, which include an obstetrician, specialist, doctor, nurse, midwife, lady health visitor, or community midwife. And postnatal care decreases with the increase in number of births. And now the age at birth, we can see that ideal antenatal care utilization was more common among middle age group 25 to 34 years compared to other age groups, while skilled birth attendance and postnatal care are more likely to be used by middle age groups as well as younger mothers than as compared to older mothers. Next. It was found that use of ideal ANC is increased with women's level of education. Women with 10th grade or higher education are twice as likely to receive ideal antenatal care than women with less than 10th grade education. Still, their proportion is small, only 43%. 85% of delivery outcomes to women with 10th grade or higher education were assisted by skilled birth attendants, while 58% were to women with no education. Now the wealth status, as we can show that as we can see that the large differentials in the utilization of ideal antenatal care by household wealth, and it increases with the increase in wealth. Women in highest wealth quintile are more likely to be received ideal ANC than women in the lowest wealth quintiles. The slide also shows that the richest women are almost twice as likely to receive skilled birth attendance than poorest women. Next. Logistic regression models depicting the likelihood of health services utilization, antenatal care, skilled birth attendance, and postnatal care for each variable shown after adjusting for the effects of age parity, women's education, residence, and wealth quintile. Now, next, please. Now the adjusted odd ratios for ideal ANC, skilled birth attendance, and postnatal care in a health facility by education. The odd ratios of having ideal ANC is much higher for more educated women having 10th grade or higher education than those with no education. The effect of education is statistically significant on the use of ideal ANC. The odd ratios of having skilled birth attendance are also much higher for more educated women than those with no education. And the effect of education is significant on the utilization of skilled birth attendance, while the odd ratios of having postnatal care is lower for more educated women than those with no education, which shows that more educated women are less likely to be used postnatal care. Parity is a good predictor of the use of ideal ANC. Women having 3 to 5 births are 2.7 times more likely to have the ideal ANC. Adjusted odd ratios for skilled birth attendance show that the women having 3 to 5 births are 1.7 times more likely to attend the skilled birth attendance as compared to the reference category 1 to 2 births. Regression results show that women having 3 to 5 births are 1.3 times more likely to be received postnatal care than those having 1 to 2 births. The odd ratios are 11.4 times more likely to adopt ideal ANC than the poorest women. As expected, the effect of the wealth quintile on skilled birth attendance was found significant and increased with household wealth. Richest women are 4.3 times more likely to have the SPA than poorest women from lowest quintile, while richest women are 2 times more likely to have postnatal care than the poorest women from lowest quintile. This shows that with an increase in household wealth, women are more likely to have better opportunities to use ideal ANC, skilled birth attendance, and postnatal care. Next, please. Now the recommendations to develop better general community-based education training programs on the importance of maternity health care services and its utilization. Awareness for utilization of ANC, skilled birth attendance, and PNC can be achieved by collaborating with the traditional and religious leaders in the communities. More qualified staff and voluntary health workers can be recruited to support these campaigns. Next, please. Education and financial empowerment of women will also need to be focused to strengthen the utilization of maternal healthcare services. Targeted strategies to overcome barriers like lack of access to quality services should be focused while designing policies. Thank you.
Thank you so much, Ms. Rabia Zafar. And we have seen that how important is maternal education and socioeconomic status. So we've clearly seen that those who are more educated and their socioeconomic status is better, they utilize the health services better and they have better outcomes as well. I will now introduce my next speaker, Dr. Qudsiya Uzma. She's a technical officer at RMNCH Department WHO since 2017. She has both masters in public health. Okay, so ma'am is very quick to come.
Bismillahirrahmanirrahim. Nahmaduhu wa nusalli ala rasulihil kareem. Thank you for the opportunity given to share the results from in-depth analysis of the Pakistan Maternal Mortality Survey, focusing on perinatal mortality. So we had in our team with me, Dr. Samina, Ellen, Ikhlaq Saab, and Dr. Fareed, of course. We'll have to go down, huh? Okay, it's a ye kaam karega. So just, looking at the birthday, which is generally a day of happiness and joy, but it is also the time of highest risk for both pregnant women and newborns. As we can see from this graph, which is showing the extent of risk that neonatal deaths and stillbirths and intrapartum, both intrapartum and immediate newborn deaths and maternal deaths that we face globally. Can we go to the next? We all know this, but just to remind ourselves how we calculate perinatal mortality, it's counting of stillbirths and early neonatal deaths and divide them by total births, including both live births and stillbirths, and multiplying by 1,000. So we'll be talking about the perinatal mortality rate. So you will be knowing how this was calculated. Please continue. This is just a background about methods, which I think has been already adequately covered by the previous speakers. I won't go into the detail. We can go to the next slide. Yeah. So this is bivariate analysis, looking at the overall prevalence in Pakistan, which is 70. But it was found that Gilgit-Baltistan is one area which had a significantly lower perinatal mortality rate. All other provinces and regions were having almost lower, but like Balochistan and Sindh was higher, and KP and Punjab was lower, but it was not significant. Coming to the wealth quintiles, it was the highest quintile having the lowest perinatal mortality rate, and it was significantly lower. Next variable that was looked at was the type of residence, place of residence. So it was almost the same for both urban and rural. Can we go down? Again, looking at the ideal ANC, we have heard what is ideal ANC by our previous speaker. So it was found that if there is ideal ANC for the pregnant woman, the risk is of perinatal mortality rate is lower, and it is significantly lower. Coming down to the type of service providers. So there are certain different types of providers which were looked at, and there are differences, but these were all non-significant. So it's like almost the same for any type of service provider. The risk is the same. Going down to the mother's parity. So if the parity is 6+, the perinatal mortality rate risk was significantly higher as compared to the lower parities. The next, mother's age group. So it was found that mothers between 25 to 34 years of age were having significantly lower risk as compared to the other age groups, the other extremes of less than 25 and more than 35 years. Coming down, by mothers' prior pregnancies, excluding the last pregnancy, again 6+ pregnancies were having the highest risk, highest rate, but this was again not significant. Mother's education level. So as was also shared by the previous speaker about maternal mortality risk. So perinatal mortality risk was also higher, was also significantly lower in mothers who had 10th grade or higher education. And likewise, if we can go to the next slide, if the head of the household has an education level of 10th grade or higher, so it was significantly lower in those cases. Coming to the next, the perinatal mortality by use of stillbirth attendance. So there was not much difference, and it was also not significantly different as well. The next, yeah, by the type of facility. So this is by public or private facility, by facility delivery. Again, this was also, there is difference, but it is not significant. And if we go to the type of facility, the next slide, which is showing government or private sector, again, there is no difference, not significantly difference. Availability of LHWs in the village and also their regular visits, both these variables were having no significant difference in terms of perinatal mortality. there was some difference shown in the figures, but it was not significant. So if we can go down. Yeah, so we also have some logistic regression using multivariate analysis. And if we can go to the first of, so the wealth quintile and comparing with the perinatal mortality after adjusting for the effects of women's age at birth, parity, and women's education, I believe. So we found that other than the higher risk for the lowest quintile, even the second lowest quintile was also having a high risk after adjustments. This was not the case when we were doing the bivariate analysis. Going to the next. In terms of the parity, we found that the 6+ parity was having a significant difference, but the other, the lower number of parities was not significantly different. Mother's age, again, in the bivariate analysis, we found that 25 to 34 years was having a lower risk, but we found that more than 35 years was having a higher risk, which was significant. Again, mother's education. So we found in bivariate that 10th grade or higher was having a significantly lower rate, but with the after adjusting for the effects of women's age at birth, parity, and residence and wealth quintile, even no schooling was also having a higher risk of perinatal mortality. Use of ideal ANC was not found to be much of a factor affecting perinatal mortality. And likewise, scale birth attendance. If in the bivariate analysis, we didn't get a significant difference, but after adjustments, use of scale birth attendance did have a was actually having a higher risk, and that can be explained due to various factors. So the key messages that we see after looking at all these findings, we can gather that wealth and geographic inequities are existing in perinatal mortality figures that we saw. And the risk of perinatal mortality increases with the increasing age of mother, more than 35 years. I think this was the same risk for maternal mortality as well. No schooling of mother and that of health of household is again a significant risk factor, and it is a similar risk factor as we found in the maternal mortality presentation. LHW's availability and regular visits basically had no bearing on perinatal mortality, and this needs further discussion and further deeper analysis, and it might be due to quality issues or other situations where LHWs are probably overworked with other responsibilities than to focus on mother and children. Use of ideal ANC again does not reduce the risk of perinatal mortality, and this might again be due to some quality of care issues. And likewise, use of scale birth attendance, and which is linked with high perinatal mortality rate, could be also due to quality of care or due to the fact that mostly scale birth attendants receive the most complicated cases, and that might be a reason for having higher perinatal mortality among those cases. So this is all about the key findings that we had on perinatal mortality in the PMMS. Thank you.
Thank you so much, Dr. Qudsiya Zafar, for shedding light on the causes of very high perinatal mortality rate in Pakistan. Let me welcome Dr. Samina Naeem Khalid. वो जैसे कहते हैं कि हर कामयाब मर्द के पीछे एक औरत का हाथ होता है, तो इस कामयाब कॉन्फ्रेंस के पीछे जिनका हाथ है वो डॉक्टर समीना नईम है. She is pioneer organizer among the pioneer organizers of Annual Public Health Conference in HSA, and she's been organizing this conference for the last 12 years. So now we'll move forward to our discussion session, which will include question answers from the participants as well. So I will request Professor Dr. Farid to please comment on the presentations. As you have seen as well, that all our presentations, they are very interlinked. So the determinants for maternal mortality and perinatal mortality, they are very interlinked, and the causes are almost same for both of them. So please, sir, put some light on the discussion.
I think the presentations were very clear. और ये हमने पहले भी देखी हुई है, तो थोड़े जिन लोगों ने देखे उन्हें ज़्यादा पता भी होगा, अंदाज़ा होगा। मेरा ख्याल है कि जो ओवरऑल मैसेज है वो मैं पहले आपको बता देता हूँ। जो मेरे जहन में आता है कि जो हमने इस पे पॉलिसी रिसर्च भी की है इसके लिहाज से कि एक्चुअली जो ये PMMS जो हुआ है ये हमें बता क्या रहा है। तो दो चीज़ें बता रहा है एक्चुअली। एक तो सिंपल ये बता रहा है कि जी वी आर स्लो इन रिड्यूसिंग बोथ आवर पेरिनेटल मोर्टालिटी रेट एंड maternal mortality ratio. And for perinatal mortality rate actually is much more slower than other countries. Maternal mortality ratio MMR के लिहाज से मेरे ख्याल है कि we are in a position to achieve the SDG 2030 target if we accelerate our reduction rate, which is right now not as much. So we will इस rate पे हम पहुंचेंगे मेरे ख्याल है 100 2030 तक, और अगर हम इसको accelerate करें तो 70 अचीव कर सकते हैं। उसकी जो रीज़न है वो मेरा ख्याल है कि इतना ज़्यादा गवर्नमेंट का उसमें हाथ नहीं है। अनफॉर्चुनेटली एक ट्रेंड चेंज हुआ है जिसमें कि हेल्थ केयर फैसिलिटीज़ के अंदर डिलीवरीज जो है वो इंक्रीज़ हुई हैं, तकरीबन 66% जो है वो पहुंच गई इस वक्त फैसिलिटी डिलीवरीज। दिस वाज लाइक आई थिंक मेरी ज़माने के 2-4 लोग यहाँ बैठे हैं, इनको याद होगा जब हमने शुरू किया था तो 20% जो है ना वाज कंसिडर्ड लाइक वेरी हाई, है ना। So I think that is one thing which is actually changing a lot of MMR at least। दूसरी चीज़ है मोबाइल फोन्स। पिछला जो सर्वे हुआ था जो उसमें मोबाइल फोन्स नहीं थे 2007 में, मोबाइल फोन कवरेज एक्चुअली इमर्ज्ड एज वन ऑफ द रिस्क प्रोटेक्टिव फैक्टर्स, कि जहाँ पे जिन इलाकों में मोबाइल फ़ोन कवरेज थी वहाँ MMR कम था और जहाँ पे नहीं थे वहाँ ज़्यादा था। अब जो है यूनिवर्सल हो गया, तो मेरा ख्याल है इसका भी एक है। और एक और चीज़ जो इमर्ज हुई है वो ये है कि फैमिली प्लानिंग इज़ डायरेक्टली रिलेटेड विद ए रिडक्शन इन मैटरनल मोर्टालिटी। सो ये तीन चीज़ें तो बड़ी क्लियर है। इसके बाद आती है पेरिनेटल मोर्टालिटी रेट। तो उसमें गालिबा जो मेन चीज़ है वो ये है कि वी हैव इशू ऑफ क्वालिटी ऑफ केयर, क्योंकि लगता है ऐसे कि अगर ख़वातीन जो जा रही हैं, जो नज़र आ रहा है वो ये कि जी स्किल बर्थ अटेंडेंट्स की डिलीवरीज़ में और हॉस्पिटल डिलीवरीज़ में PNMR ज़्यादा है। और इसकी रीज़न गालिबा यही है कि आइदर द women are reaching there very late or the quality of the care is not up to the mark, or both, and both is probably more likely. So I think that is one thing. सिजेरियन सेक्शन में तकरीबन यही इंडिकेशन आ रही है कि अव्वल तो आई थिंक फर्स्ट थिंग के मेरा ख्याल है ज़ाती तौर पे मुझे नहीं पता, हो सकता है क्लिनिशियन मुझे ज़्यादा गाइड कर सकें। सी सेक्शन की जो है वो इंडिकेशन मेरा ख्याल है उन प्रेगनेंसीज में ज़्यादा होनी चाहिए जो गवर्नमेंट हॉस्पिटल में जाती हैं, क्योंकि दे आर लाइक एट ए हायर रिस्क, प्राइवेट हॉस्पिटल में जो लेडीज़ यूज़ करती हैं उसमें मेरा ख्याल है इतना I think personally because they can pay also and they have better socioeconomic status. लेकिन यहाँ पे जो है उल्टा है कि 22% रेट आ रहा है गवर्नमेंट का, 34% आ रहा है प्राइवेट का। दिस शुड बी फर्दर लुक्ड इनटू। ओवरऑल आई थिंक लग रहा है कि जो अफोर्डेबिलिटी जो है वो डॉक्टर अमरीन ने 4 फैक्टर बताए थे, मेरे ख्याल या 3 बताए थे, उसमें जो है अवेलेबिलिटी, एक्सेसिबिलिटी और एक्सेप्टेबिलिटी, लेकिन अफोर्डेबिलिटी इज़ वन फैक्टर विच इज़ इमर्जिंग, लाइक कि अगर आप अफोर्ड कर सकते हैं तो उसमें मेरा ख्याल है कि जो नेसेसरी इलेक्टिव सिजेरियन सेक्शन और इवन अननेसेसरी, आई डोंट नो, मे बी डॉक्टर्स कैन कमेंट ऑन दैट, they are probably getting higher in terms of the numbers are increasing. Overall I think जो लगता है वो ये कि हमारा जो MMR जो स्ट्रक होगा या हो रहा है, जिस तरह से हमारा CPR भी स्ट्रक हुआ है, उसकी मेन रीजन 2 हैं। एक है जनाब इक्विटेबल डिस्ट्रीब्यूशन ऑफ रिसोर्सेज। हमारी जो सिस्टम है उसमें इक्विटी नहीं है। रूरल एरियाज और लो इनकम अर्बन एरियाज, आई थिंक लो इनकम अर्बन एरियाज आर मोर काइंड ऑफ डिप्राइव्ड दैन द रूरल एरियाज इवन। वहाँ पर जो है वो एक्सेसिबिलिटी और अफोर्डेबिलिटी हेल्थ केयर की इतनी ज़्यादा नहीं है, और उसके लिए पाकिस्तान में, हमारे मुल्क में अभी तक कोई एक्टिवली कोई ऐसी चीज़ नहीं हो रही जिससे हम समझें कि we can improve the equity of the distribution of health resources, especially for the MNCH. Next thing is the quality. I think quality is पहले भी इसका जिक्र आया है कि I think quality of imam care अगर हमारी improve हो तो probably जो है ना वो There are other studies which have shown this, that Pakistan has serious problems in quality of care, especially with regard to MNCH care, and more especially with regard to the emergency obstetric and newborn care. ये अगर दो चीजों पे अगर हम focus करें तो इंशाल्लाह I think that's my take.
Do we have any question from the participants?
My question being the perinatal Assalamualaikum. So the perinatal mortality rate provincially in GB is lower. I do understand that they have better quality of life in terms of organic resources and everything, but could it be that they have lesser reporting?
Sir, like Dr. Kutsia did mention that we have to look into the causes. It could be the quality of the study or error in sampling or something else that could have caused this. So it's not related that they are very developed or they are different than other provinces. I think it could be the quality of the study that could have.
Permission.
Yes,
Yeah.
sir.
I just want to add, it's also underreported, as you very rightly said, because stillbirth जो थी वो report ही नहीं होती. तो इसलिए there is a probability कि वो कम record होती.
Yeah, any other question? Yes, please. Give the mic.
Assalamualaikum. I just wanted to ask why there is the of mortality in mothers who have high socioeconomic status and who have higher education. Like one of the ma'ams reported.
No. You said yeah the other way. Yeah.
Okay. Okay.
It's inversely proportional actually.
Okay. अच्छा जो डिफरेंस था वो गवर्नमेंट और प्राइवेट सेक्टर वाला था कि जो गवर्नमेंट में है दे आर मोर प्रोन टू आई गेस आपने इस तरह का जो डिफरेंस था कि यस ओके थैंक यू
Okay. Do we have any other question or yes?
Thank you. So ye question, it's of special interest to me because I'm midwife, so I look at these numbers. I think I saw that by provider jo tha maternal mortality, it was CMW or DAI ko saath rakha tha and everyone else was together. So is this because you're lumping them together as untrained or kis tarah aap log ne usko identify kiya? There was CMW because I wouldn't meet a lot of people jinse main पूछूं कि आपकी delivery community midwife ने कहीं की है, उनको पता होगा कि हाँ community midwife ने की है. So that's just of curiosity to me.
ये बेसिकली पाकिस्तान डेमोग्राफिक एंड हेल्थ सर्वे और मैटरनल मोर्टेलिटी सर्वे, अगर हमारा मैं निप्स में हूँ, हमारी वेबसाइट पे देख के आप जाके पूरा पढ़ें. उसमें बेसिकली हम जो अनस्किल्ड और स्किल्ड को अलग-अलग वो करते हैं. तो कम्युनिटी मिडवाइफ्स और वो उसमें इतनी ज्यादा दाइज जो हैं वो स्किल्ड बर्थ अटेंडेंट नहीं होती, तो इसलिए उनका कंपैरिजन किया है. और आपको डिटेल में अलहदा से भी मिल जाएगा क्योंकि इसमें थोड़ा शॉर्ट टाइम है, इसलिए इस तरह. हाँ, लेकिन यह है कि आपने अगर पढ़ना है, बल्कि मैं एक चीज बताना भूल गई कि हमारा जो DHS की वेबसाइट पे आप लोगों के लिए डेटा अवेलेबल है, और आप लोगों ने किसी ने भी रिसर्च करनी हो मास्टर्स की इवन PhD की, तो आपको DHS की वेबसाइट पे ये ओपन डेटा स्टेटा और 4 वर्जन्स में मिल जाएगा. आप लोग इस पे मजीद इन डेप्थ खुद भी कर सकते हैं, एनालिसिस भी कर सकते हैं, और अगर निप्स के साथ चाहें आकर करना तो हम लोग भी इन डेप्थ एनालिसिस करते रहते हैं. तो अगर हमारे साथ भी आप लोग करना चाहें तो यू आर मोस्ट वेलकम. थैंक यू.
Can I just respond to your question? I think Aisha ने respond तो कर ही दिया है, but community midwife की बात हो रही होगी तो वो community के जो providers हैं उनको अलग करके किया होगा. Otherwise community midwife is a skilled provider. जो सिर्फ दाइयां हैं जो उनका है कि वो they are unskilled, untrained, but community midwives, you know, they are skilled and they are skilled birth attendants. So that is.
मैं ऐड करना चाहूंगी. मेरा ख्याल है आपका सवाल ये था कि जो रिस्पोंडेंट है उसे कैसे पता कि मेरी डिलीवरी जो है वाइफ ने की है। तो हमारा जब हम क्वेश्चंस करते हैं हमारे इंटरव्यू कि आपको किसने डिलीवरी में असिस्ट किया था, तो जो है तो खातून है, उसका कहाँ बैठ जाता है हम रिस्पांस को उस कैटेगरी में डाल देते हैं। थैंक यू।
Thank you so much. I just also have a question. As all of you are sitting and anyone can answer, what were the challenges that you have faced when this survey was done? Please, Maya, give the mic to Dr. Aisha. Because it's so you're all so related to each other.
फील्ड के चैलेंजेस तो ये थे कि हमारे नॉर्मली तो एक हार्ड एंड कोल्ड वेदर भी बहुत बड़ा चैलेंज होता है सर्वे करने के लिए, फिर हमारा सिक्योरिटी कंसर्न्स होते हैं, धरने हो जाते हैं बीच में, फिर इस तरह होता है कि लोगों के खास तौर पे जो हाई वेल्थ स्टेटस वाले लोग हैं, पॉश एरियाज हैं, वहां पे हमारी पूरी टीम रिसर्च करने जब जाती है फील्ड में तो हम उनकी ट्रेनिंग करते हैं, पूरे प्रोविंस से अखबार में इश्तिहार देके लोगों को हायर करते हैं, और फिर जब वो फील्ड में जा रहे होते हैं तो उनकी कम से कम 20 से 25 डेज की ट्रेनिंग के बाद वो करते हैं। फिर भी उनको जो हार्डशिप्स फेस होती हैं यही होती हैं कि लोगों का रिस्पॉन्स नहीं, जैसे आजकल एक रिसर्च चल रही है तो उसमें ये मसला आ गया कि किसी ने कहा कि जी बच्चे उठा रहे हैं और ये आपके बच्चे गिन लेंगे सारे और उसके बाद आके तो बच्चे उठा के चले जाएंगे और गुर्दे निकाल लेंगे, ये भी तो हमें इस किस्म के भी चैलेंजेस फेस करने पड़ते हैं। फिर इसी तरह बलूचिस्तान में हम जो है फिर हम ऑन बोर्ड ले लेते हैं, आर्मी को हम सबको लेटर्स लिखते हैं, होम ऑफिस को लिखते हैं, वहां के डिपार्टमेंट कभी थाने वाले पकड़ के ले जाते हैं, कभी 15 को लोग फोन कर देते हैं कि जी आपकी जो है ये पता नहीं कौन लोग आ गए या कुछ है, तो हम पहले उन्हें लेटर्स लिखते हैं क्योंकि हम गवर्नमेंट ऑफ पाकिस्तान का इदारा है तो हमें उनकी भी सपोर्ट होती है, डिस्ट्रिक्ट ऑफिस हेल्थ के, पॉपुलेशन वेलफेयर के, होम ऑफिस, थाने, सबको हम ऑन बोर्ड लेके एनओसी लेके फिर हम रिसर्च करते हैं। तो ये सारी हमें प्रॉब्लम्स फेस होती हैं, तो इनको हम कोशिश करते हैं केटर भी करते हैं चैलेंजेस जो फेस होते हैं, लेकिन ज्यादातर यही होते हैं, सिक्योरिटी कंसर्न है, लोगों का नॉन रिस्पॉन्स होता है, हाई एरियाज में लोग दरवाजा ही नहीं खोलते, तो इस तरह के भी चैलेंजेस।
Thank you so much, Dr. Aisha, for responding so well.
May I add something here?
Yes, sure, please.
एक बहुत crucial issue है जो basically when you look at introspect within the team, कि हम जो टीम मेंबर भेजते हैं उन पे हम कितना रिलाई करें कि वो सर्वे करेंगे जाके।
Exactly, yes.
ये बहुत बड़ा क्रिटिकल इशू होता है कि जब वो देखते हैं कि एक लंबा इंटरव्यू हमने करना है तो वो फिर इधर दे वांट टू एलिमिनेट द डेथ और एलिमिनेट द इन्फर्म मोर्टेलिटी और चाइल्ड मोर्टेलिटी ताकि इंटरव्यू ना करना पड़े। तो इस सिलसिले में हमने जो इंटरव्यू टीम थी उसमें एक स्पेशल लड़की रखी हुई थी जो सिर्फ मटरनल मोर्टेलिटी का सर्वे करेगी और इंटरव्यू करेगी ताकि उस पर बोझ ना पड़े जो डिटरमिन कर रही है कहाँ पे डेथ हुई कहाँ नहीं हुई। मगर उसके बावजूद मैं नाम तो नहीं लेना चाहता, मगर हमें सिंध में और बलूचिस्तान के कुछ ऐसे इलाके थे जहाँ पे मटरनल डेथ हुई थी, we could figure out from the house of schedule, मगर वहाँ इंटरव्यू नहीं हुआ because of the elimination of such cases. तो हमें वहाँ दोबारा जाना पड़ा था ताकि मुकम्मल कर सकें। तो ये बहुत इंपॉर्टेंट होता है कि we basically look at the quality of data and the quality of the interviewers that we hire and their reliability that they will send the quality data.
Thank you, sir.
वर्बल ऑटोप्सीज की थी, मैटरनल डेथ्स की वर्बल ऑटोप्सीज की थी, इसमें हमें बहुत ज्यादा मतलब मुश्किल का सामना हुआ क्योंकि जो खातून अगर मर गई है तो हमें वो लोग चाहिए थे जो उसके मरने के वक्त में, उसके बीमारी के वक्त में उसके साथ थे, अगर वो हॉस्पिटल गई है तो उस टाइम में भी उसके साथ थे। तो ऐसे लोगों को ढूंढना और फिर मतलब जाना बार बार उनके घर के, अच्छा वो आपका भाई था अस्पताल में, प्लीज उसको भी बुलवा लें, तो ये एक बहुत ही मुश्किल काम था। और फिर जाहिर है उनके तो घर की खातून फौत हो गई है तो उसके मुतालिक फिर वो तमाम तर हिस्ट्री को रिपीट करवाना और सारी चीजें पूछना, तो वो ना सिर्फ उनके लिए मुश्किल था बल्कि हमारी जो इंटरव्यूअर्स थी उनके लिए भी बहुत मुश्किल था कि आपको हर रोज मतलब पता चल रहा है कि ये खातून इस तरह
ये
से
के
बहुत
साथ
हो गई,
ही।
तो वो काफी मुश्किल काम था। और लेकिन हमने ट्रेनिंग की हुई थी, तो हमारे माशाल्लाह इंटरव्यूअर्स ने बहुत अच्छा डेटा कलेक्ट किया।
Thank you so much, Ms. Rabia. I asked this question because I want my participants to know that the slides they're saying or the results they are saying, it's not an easy job. So you have all listened that how difficult it is. It's not something that, you know, you're sitting in your office and you're putting data in the computer and you get the results. So it's a hard job. It's a field job. It's
एक
a
चीज
hard
और
job.
ऐड करना चाहूंगी, असल में हमारी ज्यादा प्रेजेंटेशंस थी जिसमें बेसिक मेथडोलॉजी भी थी इस सर्वे की, जो हमने अभी प्रेजेंट नहीं की। तो ये है कि आप लोग वही हमारी रिपोर्ट को जाके पढ़ भी सकते हैं और देख भी सकते हैं कि ये पूरी मेथडोलॉजी थी किस तरह के। हमने पहले एक बड़ा सर्वे किया था, उसमें हमने डिटेक्ट की थी कितनी मैटरनल किसी के घर में कोई भी डेथ हुई है। फिर वो अगर मैटरनल डेथ थी तो उसके लिए फिर हमने वर्बल ऑटोप्सी की थी, और वो फोकस ग्रुप की तरह की थी, यानी 5-6 लोग उस फैमिली के बुलाकर, एक बंदे से इंटरव्यू नहीं किया था, 6-7 लोग बिठाकर जो उस वक्त डेथ में उनके करीब था, और उनके इंटरव्यूज करके फिर हमने उनको सारों को जो है एक जगह कंपाइल किया था। फिर 3 डॉक्टर्स की NMC की जो कमेटी थी, वो डॉक्टर्स थे, उनको हमने 3 डिफरेंट डॉक्टर्स को वो केसेस दिए, और फिर उन्होंने पढ़ के उनकी कॉज ऑफ डेथ डिटरमिन की थी कि वाकई मैटरनल थी कि नहीं थी,
Something else.
और फिर उसमें से डोमेस्टिक वायलेंस एक्सक्लूड कर दिया। और इस तरह की पूरी डेफिनेशंस हैं, तो स्टूडेंट्स जो हैं इसको पूरा पढ़ें तो ही हो सकता है, अदरवाइज हम वैसे कभी जरूरत होगी तो हम एक प्रेजेंटेशन इस
We
पे
can do that as well.
स्पेसिफिकली दे भी सकते हैं आपके स्टूडेंट्स के लिए। लेकिन क्योंकि बच्चों को ये चीज डिटेल नहीं पता, हमने सिर्फ इन डेप्थ किया है, तो हो सकता है बैकग्राउंड उनको ना समझ आने में। तो आपका थैंक यू कि हमने थोड़ा सा इस हवाले से
No
बता
problem.
दिया।
So as you, all the participants know that Dr. Aisha has mentioned that there's a lot of data that's available at the DHS website, so you can use it very effectively. Dr. Athiya, I would like if you can comment on something or for some notes.
Thank you, Dr. First of all, I would like to thank HSA and all the organizers who have given me this opportunity to be a part of this important session in this 12th annual conference. As far as we have listened to the in-depth analysis, I must congratulate NIPS for conducting this in-depth analysis. It was very necessary to look into the actual causes and actual data and the results and recommendations, which will definitely help us to design interventions for reducing maternal mortality. We will be taking into consideration all these results of this analysis so that we can plan further how to move forward with especially the issue of quality of care, which has been highlighted, and also among other factors, the use of family planning methods, the modern methods of family planning, and obviously unsafe abortions.
Yes.
So government is very much cognizant of all these factors which are contributing to increased maternal mortality in Pakistan. And Pakistan, as we all know, is among those countries which have highest maternal mortality rates. Not only that we are aware of all the facts, we are constantly working, because Ministry and Government of Pakistan is right now very much focused on universal health coverage. You all must be knowing this, and among the interventions that have been prioritized in the universal health coverage package and all those essential health services packages that have already been endorsed by the provinces and the federating areas, the interventions related to reproductive, maternal, newborn health are like more than 50% of the interventions that are prioritized are related to RMNCH. So this shows how much is the government's focus on improving the health outcomes of mothers and their children. And we are constantly working with the support of all the provincial departments of health, and we are very much thankful to all those partner organizations, UN agencies who are with us, standing with us, and especially the academic institutions and the institutes like NIPS, which have provided us the evidence for working on these lines. They have just informed us about the main issues, the actual causes for which we have to work for. And we are very much focused and we are working on this. Different interventions have already been undergoing, like to name just a few. With the support of WHO, we are working on a maternal and perinatal death surveillance and response system. And previously it was piloted in just 2 provinces, in the province of KP and Balochistan, but now it has been scaled up to Punjab and Sindh as well. UNICEF is also supporting us, and previously UNFPA supported this for the community-based MPDSR in Punjab. Similarly, we are also working on strategic reforms for LHWs, because we all know that LHWs are the backbone of health system, and they are those community health providers who are going door to door. And basically, they are not only working for the provision of MNCH services and health education, but now their scope of work has been widened, and we have revised the basic curriculum of LHWs, and it will soon be implemented. We will start its implementation, and this LHW curriculum not only includes MNCH service provision, but also all other interventions which are included in the essential packages of health services, which are going to be started at the community and first level hospitals. So similarly, we are also working on reducing the abortion rate in Pakistan, because we know unsafe abortions are one of the major contributors to maternal mortality, and much work has not been done in this area. But now we are also focusing this, because we all know that unsafe abortions are widely used as a contraceptive method in our society, and women who do not use contraceptives for one or other reason, they go for unsafe abortions, and it needs to be worked upon. Then I would also like to add that government is also working on improving the midwifery services in terms of revising the curriculum for midwives, which has already been revised in line with the ICM standards, and it is under the process of approval by HEC. And similarly, we are trying to increase the coverage of services by increasing the number of community health workers, including lady health workers and community midwives as well. So these are just a few initiatives which have been, which are in pipeline by government, and hopefully keeping in view the results of this in-depth analysis, we will be very much looking forward to all the stakeholders and especially our partner organizations for supporting the interventions which are targeting to improve the health of our mothers. With this, I once again thank all of you.
Thank you, Dr.
I
Athiya.
hope that we will be working together jointly in future as well for this important cause. Thank you.
Thank you. You're welcome. Thank you, Professor Dr. Farid, Dr. Tausif, Dr. Nabila, Dr. Athiya Abru, Dr. Samina, Dr. Qudsiya, Dr. Aisha Shiraz, and Ms. Rabia Zafar. I would like to welcome Professor Dr. Farid to please present the shields to the chair. Sir, please, will you please come to present the shields to the chair? So you will present to the chair, and then chair will present to you. Dr. Nabila, please, will you also join? Dr. Athiya, please. Okay, can I request Dr. Nabila or Dr. Tasif to present the shield to Dr. Farid? Okay, now I will request, can you please stand for a few seconds so we can have group photo and certificates for the speakers as well. Okay, so I will request Dr. Aisha Shiraz to please come. Now request Dr. Qudsi Ozma to please come. Okay.